please join me in welcoming her. Sofia, you have the floor now.
Thank you very much for the nice introduction. So indeed, my talk today will be about the automatic detection of risk factors in pregnancies in low-risk settings, and my focus in particular will be about the development of the BabyChecker. I am a PhD candidate at Radboud UMC, and this is the team that I'm working with, which gathers expertise in automated image analysis, ultrasound imaging, and also tropical medicine and gynecology. As we have heard today, maternal mortality is extremely high in some regions of the world. And in particular, of the 300,000 maternal deaths worldwide, 70% of them occur in sub-Saharan Africa only. And what is important to note is that given the current knowledge and technology that we have, most of these deaths are actually preventable. And this is why the World Health Organization, in its 2016 antenatal care recommendations, suggests the use of an early ultrasound scan before 24 weeks of gestation in order to identify any pregnancy complications and properly manage them. But there are some limitations to the use of ultrasound as a screening tool in low-income countries, and one of them being the high cost of the ultrasound devices, the other one, the lack of trained sonographers. And this is why with the BabyChecker, our main aim is to introduce low-cost ultrasound in combination with automated image analysis to detect high-risk pregnancies in low-risk settings without the need of a trained sonographer. And because this product has to be suited for novice operators, we have adopted the obstetrics protocol, which Julio briefly talked about, and was introduced by Kirsten de Stichter from Imaging the World back in the year 2011. And this protocol consists of 6 standardized sweeps over the graphic abdomen, 3 vertical ones in the transverse plane from bottom to top, and 3 horizontal ones in the sagittal plane from patient's left to right. And if we play this video, we can see an example of a midwife following this protocol and scanning the patient. Can we see the video playing? Yes. So we can see an example of a midwife acquiring data from a patient and following the protocol that with the instructions that are on the screen. And again, as Julio said, this requires no prior knowledge or expertise in ultrasound, and it can be taught within 1 hour. And the BabyChecker integrates well with the healthcare system in these settings, as in the triage system that Julio explained, in which we can see in the initial phase where the patient, this is an outreach, or the patient will go to a healthcare center, they'll get an ultrasound scan, and 2 possible outcomes will come out from this. Either there is no risk in this pregnancy, so we would like to schedule a next visit and the patient can go home, or else there is some risk identified, and then this patient needs to be referred to a proper level of care. So this is, in a nutshell, what the BabyChecker concept is about. And I would like to now move on to the main part of this talk, which concerns the research that was performed at Radboud UMC. And for this, I would like to credit my colleague Thomas van den Heuvel, who was the main researcher working on this and whose work I'm going to be talking about today. So the first initial step for developing the BabyChecker was to test whether low-cost ultrasound devices and the obstetrics protocol were sufficient for estimated gestational age. And for these, 60 participants were scanned using 4 devices, 3 low-cost ultrasound devices, which you can see in the 3 columns to the right of this image, and 1 high-end device that was used as reference, the Volson, which you can see in the left. And the main goal of this study was to evaluate the accuracy in gestational age estimation, both with images acquired with low-cost devices in comparison with the high-end device that's a reference used in clinical practice, as well as following the standardized protocol that I talked about earlier. And two main conclusions were drawn from this study. First, on the head circumference planes that were acquired with the low-cost devices fall within inter-observer variability reported in literature. So this is good, we can use low-cost devices. But in addition, we also reached the conclusion that gestational age can be estimated properly through the measurement of head circumference on scans acquired with low-cost devices following the obstetric sweep protocol. So this led to the proof of concept of the BabyChecker as a product or as a working solution. And then it was tested back in the year 2016 in Ethiopia, and its ease of use was confirmed among midwives that received 2 hours of training. And I would like to now move on to a bit more technical part in which I want to explain how the BabyChecker works in the backend, what the AI part consists about. And for this, one of the initial steps that happens in the application is the classification of the different ultrasound images that are acquired. So we're interested in knowing the content of these images, and we classify them into some categories. For example, we see a full fetal head in the field of view. We see a partial view of the fetal head. We see parts of the torso, a side view of the fetal body, or even if the transducer is detached, that means that the probe is not making proper contact or no contact at all with the patient's skin. And anything else now falls under the other category, which we are not currently using. And why is it useful to know the content of these images? For example, going back to gestational age and explaining a bit more in depth how we can derive it. If we know which images contain a full view of the fetal head, then we can run a segmentation network that identifies all the pixels where the fetal head is. We then fit an ellipse to it and to estimate the head circumference, and through some curves, we can estimate the gestational age. And you can see here that there is a good agreement between the measurements estimated using this method that you can see on the y-axis with respect to the reference acquired in clinical practice in the x-axis. And another part, another useful case scenario for this frame classification is fetal presentation. So here we can see a video that I'm not sure if it will play on its own. Yeah, it starts playing. So in this video, we can see that in the beginning, in blue, we have some frames with fetal head, then we have some fetal torso, and in between other structures, and then we can see some black parts in the image that they correspond to the transducer being detached. And this means that we have ended sweep 1 acquisition, which if you see the image on the right, you can see that it goes from the bottom, the midline, patient's midline from bottom to top. And every time we see like these dark parts, these dark images in this volume that I'm drawing here, then it means that we are moving on to another sweep because we lift the probe. And right now, this might not seem like really straightforward to you. It's not really readable for us. But what we do is we rearrange it in space in a way that we can actually understand, and that is related to both the protocol that we see on the right and closely to the patient's anatomy, because they're both closely related. And what we can see here is in blue some frames of fetal head and in green a fetal body. And we see that there are some fetal head at the bottom. And then because we know that these sweeps were acquired low in the abdomen, we know that this fetus is in cephalic lie. Analogously, in this case, we see that the opposite happens. We see some frames of fetal head at the top of the sweeps or the top of the abdomen and some frames of fetal torso at the bottom, which means that we have a case of a breech pregnancy, and this case is really important to identify because we should refer to a proper level of care. For this task, the BabyChecker performed with 100% sensitivity and 99% specificity on a test dataset containing 31 breech pregnancies. And following the same logic, in this other case, from another patient, what we can see is that we have some frames of fetal head at the bottom, so at the bottom of the abdomen, and some frames of fetal head at the top, and in between we see some frames of fetal body. So we can easily see that this cannot be the same baby. So we are in front of a case of twin pregnancies that are lying, fetuses are lying in opposite direction. And this also constitutes a risk factor that we should identify in order to refer the patient to a proper level of care. The twin detection is currently ongoing research. Because one of the challenges are, well, fetuses that lie in the same position. So you can imagine that having two heads and two torsos next to each other, then the previous approach runs a bit short. And another challenge is that in our whole data set, because of its low incidence, we have a low amount of twin cases. So we are now working towards the development of a model that can be trained mainly on single pregnancies. And we are moving on, instead of a frame classification approach, we are now working on segmentation approach, in which we segment different fetal parts. We align them in space, and through a rule-based system, we can identify each of the different fetuses and count them to know whether this is a single or multiple pregnancy. And lastly, one of the other applications that we have worked on is the localization of placenta. For this task, what we do is for every input image that we acquired, we send it through a network that performs a segmentation task, which means that it identifies all the pixels in each of the images where placenta is present. And if we render this into the whole volume, now again, you should visualize the sweep protocol and the abdomen that we have. Each of these numbers from 1 to 6 represents one of the 6 sweeps. At the top, we have the reference annotations, and at the bottom, the model segmentation. And for this task, we're currently using only the first 3 sweeps, so the vertical ones. And it's a lot easier if we visualize them but while rotating them. So sweeps 1, 2, and 3 here correspond to the orange arrows in the image to the right. And what we can see is that in all 3 of them, the placenta is located higher in each of the sweeps. So this means higher in the abdomen and in the uterus by extension, which means that this is not a case of low-lying placenta. So there is no risk, and this patient can go home and the next appointment can be scheduled. For this task, the BabyChecker performed with a sensitivity and specificity of over 80% in a test data set containing 16 low-lying cases. And lastly, I also wanted to acknowledge the clinical team and collaborations that we have. So Jeroen is also part of my supervision team, so you saw him earlier on my slides, but Anouk is an obstetric sonographer that provides a lot of input about some ideas and things that are necessary, and Camilla and Stein are research medical students that joined for internships and are actively analyzing data as well. So I would like to thank everyone for your attention.
Thank you. Thank you so much, Sofia. Understanding how the BabyChecker AI works is very interesting, I have to say that.